Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Well, it's an interesting article about being hospitalized with asthma and COVID is not associated with good outcomes. And this article talks about the fact that asthma and COVID don't get along, and that the ventilation that is required for both diseases is something that requires special treatment. And of course, one of the first things you want to do is try to avoid COVID-19 by getting vaccinated. And there's a graphic that shows the mortality rate go down among patients with no COVID and asthma and those with COVID, and you can see the remarkable difference. And those of you who don't have asthma in your family may not recognize that that is a chronic disease that is associated with mortality on its own. People who are in the 40s and 50s can suddenly get asthma and die. And there are people who have chronic asthma and die. All of us have family members, I'm sure, who've died of asthma. And so it's a chronic disease that in itself is problematic. And that's why people who have respiratory problems, in addition to people who are obese, have a high mortality rate with COVID. And so this is an article that points out that those two conditions together are associated with a much higher mortality rate, in addition to the morbidity that they have when they're in the hospital. Many of you have family members with asthma or any
I
chronic
do.
disease?
I have asthma, and I said I got it at 50. That's when it began to bother me, and I was literally sick at work, couldn't breathe, and they rushed me to the hospital. Oh, you have an asthma attack. Well, I don't have asthma. And they said, well, you've had it for years. It may have laid dormant for a while as a child or after a child, but I have asthma. And the surprising part of it is I have an older brother, and he was about 7, 8 years older than me. And a few years prior, he got asthma. Well, apparently he's had it a while. But asthma, of course, is something that can be controlled. He didn't control it. And my older brother passed several years ago from an asthma attack. And to me, it was something basic, taking medication, follow the doctor's regulations, see your doctor. And it is important. And it's especially important now, like you said, Dr. Callender, with COVID. Asthma can be very much affected or increased due to the COVID situation. But so
Right.
yes, I'm aware.
And asthma itself is a disease that is particularly prevalent among our people of color. And of course, with the air and pollution, that makes it even worse. And so there, many asthma patients can be managed satisfactorily with multiple medications, but some patients, in spite of that, die, as you mentioned, with your brother. And I had a sister who died from asthma. I have a niece who has asthma, but has had it well managed, and she's now 80 years of age. So, well, I'm sorry, I shouldn't say that. She's 78. So, yeah. Any other comments about asthma and something?
Yes. Good morning, everyone. Pearl and I had a sister also to die from asthma. She had an asthma attack. She died at 42, I think. But she lived in Florida, and I remember her saying that the doctors told her that wasn't the best climate for her, but she loved Florida, I guess, and she just had an attack and died on the street.
Yeah, it's interesting that there's some people who have their first episode just like Janice did at later age, and some of them succumb and die from it right there on the spot, and others survive and have it as a chronic illness.
And something
Well,
else I wanted to say too, she was one of two of Mama's children, sister, that were born at home. And we used to tease her. I did anyway. Used to tease her because she always did have a little cough or a little tickle in her throat. And I used to tease all the time, tell her that that's because she was born at home. And I often wonder, I often wondered whether that had anything to do with her asthma. But
well, since most of us, many of us who were born at home because they wouldn't let us get into the hospital because of our complexion. So it's an interesting phenomenon that many Black children are, at least back in the 30s and 40s and 50s, they didn't have a place for us in the hospital. And so
I
many
don't
of
really know why I don't know why she was born at home. Pearl might know more than I do, but I
She didn't make it to the hospital in time.
okay.
yeah.
Yes. Yeah.
John,
Yes, I had a question for Betty. What about Florida was bad for her asthma? Do you know?
I don't know. I think the moistness of the climate or something. I think that's what she was mentioning.
The
But she
humidity?
just loved Florida, so she lived on the west side, I think, the Gulf Coast side of Florida.
Okay.
And the reason why I think about it now, since we're on the subject, and it goes back to my brother, and he had it worse than I did. And again, not taking medication. I was the last one he talked to. And that night I checked on him because I knew he wasn't doing well. His words, baby girl, this damn asthma is going to take me away from here. And he was gone the next day. He knew he
really?
wasn't. Oh my God, yes. Yes. Yeah. But, take a pill, take your inhaler. He was overweight, didn't want to lose weight. Those were his words. Yeah. Mm-hmm. So take care of yourselves.
I had a ex-daughter-in-law who has asthma, and if I'm not mistaken, one of her children inherited the asthma from her. And he's my grandson, and he only had it for a short period of time, and then it went away, and we were all happy about that. I think, Carol, do you know what age he had asthma and what age it went away? He didn't have it very long because he was young. It was before he was a teenager.
No.
So it is a disease that's associated with heredity, and so it is in families, just as you have identified it. Yeah. Okay. Oh, Jacobet?
Yes, sir. Thank you. Hello, everyone. Um, does the asthma increase the possibility of heart attacks or strokes? And the reason I'm asking, my POA client had an adopted child who had uh, um, asthma and was controlled, and he took his medicine. He did everything pretty good. And he was 43 and going to visit a friend and stepped up to the porch of the friend's house and dropped dead of a heart attack. I'm just wondering if there's any collaboration there.
You mean association between heart attacks and asthma?
Yes, sir.
Yeah, there's none that I know of. But I haven't researched it, but I don't know of any association of asthma with myocardial infarction and coronary artery disease. So that's something
Yes,
we could look up. But offhand, I don't know any correlation between asthma and heart attacks.
I see. Thank you.
Does, Dr. Callender, does that also include strokes?
That's
No.
correct.
Okay.
Right. Because those are both cardiovascular diseases. This is another article that talks about the fact that Asians and Hispanic people have a higher risk for alcohol-associated liver disease, and it has a nice graphic there that kind of shows the difference between normal people, people who have different ethnic groups, and how the high association of liver diseases, alcohol-related liver diseases, is with relationship of other ethnic groups and Asian and Hispanics, and you can see that is interesting. This article says that we drink more than any other group, but have the lowest incidence of alcohol-related liver diseases, which is interesting. But it does identify that the Asian and Hispanic population have more alcoholic liver disease than any other ethnic groups. They also are associated with cancers as well, especially the Asian Pacific Islander group. It's interesting that we identify them in that fashion because there's so much variation on a theme in the Asian Pacific Islander population. And why we put them together as one has always been a mystery to me. But nevertheless, that's we have done that. Consider them. Yes, John.
So is this alcoholic, the ALD, is that because of drinking alcohol?
Yes.
Oh, okay.
Yes. And that's something that, and as I mentioned, we drink more than anybody else, but yet we have the lowest rate of alcoholic liver disease, which is interesting. It's a rare disease in which we have less of it than anybody else. Yeah. So, and that goes back to the discussion that we've had when the Bible says a little is good for the stomach's sake, and then some of you have mentioned that your doctors have told you that you can take one drink a day that will prolong your life, and some data supports that, and then others say that no alcohol is the best alcohol. But anyway, that's the interesting discussion. Any other comments or questions about this article? And the data is pretty large. We're talking about 98,000 folks. Okay, next article then. Well, this is an interesting article because I'm not sure that I totally agree with this. The promise of anti-amyloid therapy is a new era in Alzheimer's treatment. For the first time, we have treatments that can change the course of this disease. It doesn't cure the disease. It may delay the progression. It may delay the progression of Alzheimer's, and that's why they are saying that these anti-amyloid, because amyloid is thought to be the key factor in the development of Alzheimer's, and these anti-amyloid medications may slow the progression of by 30%, which to me is a pretty low figure, but it's better than zero. So, and I think that's why people are optimistic I'm less optimistic about it than they are, because I would be happier if we found a cure for the disease rather than to say in 30% of the patients we can delay the progression of the disease. But that's 30% is better than zero. So we're making progress. And so therefore the anti-amyloid medications are now recommended, whereas before we really had zero medication that would delay the progression of disease. And now we have anti-amyloid medications that in 30% of the cases may delay the progression of the disease. So that's good news of a sort. Any comments about this? As all of us have a family who have Alzheimer's, and we are dealing with them in a variety of different ways, supporting them in every way possible without putting too much weight on any single family member with the
Something.
patient with Alzheimer's. Yes, Betty.
I saw something in the article that said your insurance is kind of slow to catch up with paying for.
Well, as long as it's experimental, insurance is not going to pay for it.
Okay.
As soon as it gets from the era of experimental to the state of the art, then they will pay for it. But early on, you're right. When it's experimental, insurance companies not going to pay for it. That's correct.
Yeah, you said that before. That's right. Yeah.
Okay. Next one. What you do when the patient has a PSA test, you should do a digital rectal examination and give them the test. Now, here's what the problem is. Prostate cancer is without question second most common cancer in the male population. And it particularly affects Black men more than any other ethnic group. And we also know that before 75, that a digital rectal exam and PSA test will give you an early identification of cancer. The problem is after 75, are you then with the PSA causing more people to get tested and get biopsies than is necessary? And so that is an area of great discussion, and the data suggests that, as we had discussed yesterday, that when the PSA is elevated, that probably an MRI-directed biopsy is probably the most important thing to do when the PSA goes over 4. And so, yes, a PSA test, if the patient wants to have it, do it. Yes. Also do a rectal examination to see if the prostate is normal. And if the prostate is normal, then MRI of the prostate will help you with what the next tests are necessary. Some people feel that over 85, you don't need to do PSAs, but I think that PSAs are still important just to do, since we know all men are going to have enlarged prostates or are going to have prostate cancer. Then it becomes important to say yes if they want it. If they ask for it, give it to them. That would be my answer, although there's a lot of discussion, but particularly in the African American population, I think it's important for us to continue to get PSA tests, even over the age of 75. And but that's where the discussion occurs. Any comment on this? Because this is something that is particularly important for our Black men.
I had a question, Dr. Callender. Why would doctors be hesitant or not willing to give the PSA?
Because they think that if you have an elevated PSA, you may need to have a biopsy, and the biopsy is associated with complications, with urinary tract infection and those kind of things. So they want to minimize the need for the biopsy, and so that's why. So because they feel that the biopsy may be unnecessary, and and the necessary risk for urinary tract infection.
Okay.
And so they have a good reason for it. It's just that with the Black population, because of our extreme association with benign prostatic hypertrophy and prostatic cancer, that we have a special reason why we need to be more sensitive.
So, Dr. Callen, I got a question about, since mostly all Black men will eventually get prostate cancer, the treatment is started early. And so they are taking medicine now to try to offset the eventuality of prostate cancer. So
What medication are you talking about? I don't know of any such medication.
there's medication to help offset the eventuality of prostate cancer, isn't
No,
there?
that's not the purpose of the medicine. The purpose is to shrink the prostate so that you don't have enough symptoms of prostatism, which is different from eradicating the possibility of prostate cancer. They're two separate things in many ways. Benign prostatic hypertrophy will give you increased urination at night and increased urination. And so we have medications that reduce the size of the prostate, but I don't know that there's any evidence that it decreases the incidence of prostate cancer.
Okay, well, I must be getting confused that the size of the prostate cancer, if it enlarges,
An enlarged prostate does not mean that you have prostate cancer. Benign prostatic hypertrophy may be the commonest prostatic disease, but it is not cancer. But they're two different diseases. Benign prostatic hypertrophy, you can take medication to shrink the prostate, and that's what most of the medications you take do. Now, in terms of treating the cancer, the estrogens and other anti-testosterone medications treat the cancer.
that answers my
But yeah, those treat the cancer. Whereas there's other medication that just shrink the prostate, which is different from the estrogen type medications, which actually treat the cancer.
Okay, thank you for that. That's cleared that up for me. But that's a mouthful. I can't say that. Benign prostatic something. That's a mouthful. Hypothesis.
But the medication does work to decrease the size of the prostate and to try to eliminate the symptoms of frequent urination and nocturia, which means that you get up at night to urinate. Okay, this is an article that talks about it's a very good diagram there that shows a link of multiple sclerosis to bladder cancer, brain cancer, and cervical cancer. These are cancers that are more often associated with people who have multiple sclerosis, which is a disease which is the older you get, the more likely you are to get it. And we do now have medication that actually treats multiple sclerosis and does away with much of the symptoms of multiple sclerosis, which can be a very troubling disease. Anybody on this phone have multiple sclerosis or have relatives who have multiple sclerosis? Because it presents itself in so many different ways.
Yes. I have a niece now that has multiple sclerosis, and my husband's sister died from multiple sclerosis, and I also had a friend who died from multiple sclerosis. But I can say that the treatments today are much, much better than it used to be, because my niece if you didn't know she had multiple sclerosis, you wouldn't know it by looking at her or by, the way she is acted. But the other two people that I mentioned, my friend and my sister-in-law, both end up being bedridden because of MS. But
Yes,
my niece is still vibrant, and she's in her mid-60s now.
right. And I have the same experience. I have in the other days they would die or be disabled, whereas now uh, monoclonal antibodies actually allow them to be working and to do all kinds of things without any symptoms or with minimal symptoms.
And my niece tells me the only thing that really bothers her now from her medication, it breaks her skin. She has a lot of bumps and stuff on her skin sometimes because of the medication.
Mhm.
But other than that, she doesn't have the physical problems.
Mhm. Okay, thanks for sharing. Any other comments or questions about multiple sclerosis?
This statement that people with MS have a lower risk for prostate, colorectal, and breast cancer. To me, that's very strange.
Yeah, yeah. Well, that's it. That's an interesting aspect of multiple sclerosis. On one hand, you have an increased risk, and on the other hand, you have decreased risk.
And what is MS exactly?
It's a autoimmune disease that affects the central nervous system, and it can involve any organ system from the head to the toe. And often you have people who can't move at all, and you have some people who can't see. You have it acts on any area where you have a central nervous system where the nerves are involved. So they can be paralyzed. They can be affected in so many different ways. So uh, that's why it's treated by usually by neurologists, and they now have monoclonal antibodies that they use that they give you injections maybe 3 to 4 times a year. Some people just a couple of times a year, and it decreases the likelihood of the MS symptoms, multiple sclerosis symptoms.
Is that infusion?
Yeah. Mm-hmm.
And what is infusion as opposed to injection?
That usually just means you get it intravenously. Injection usually means intramuscular.
I have a choir member who has MS, and she tells me of her episodes, but as far as seeing visible signs, she might say, I'm weak or this, but she continues walking and climbing steps and staying active in the singing aggregation. But she does tell me, well, this is a down day or something like that, but she has a wonderful disposition. And it's not what I picture of someone that has MS.
Right. It's amazing the medications we now have that, as somebody had mentioned, is so different from how it used to be.
I remember when my girlfriend first got multiple sclerosis, when she found out, she was at work, and when she got ready to go home, she couldn't walk.
Yeah.
And she wondered what the problem. Someone had to come get her car and all that. And that was the beginning of her.
Yeah.
And then it would go away, and then the next episode, she couldn't see good, and
That's right.
so it just went all over her body, and eventually
Right.
she was bedridden, like I said, and she was, I think, like 42 or 43 when she passed.
Yeah, that's how it used to be. How it used to be. Okay, next article. Thanks. Well, this is as pancreatic cancer is associated with a 5-year mortality rate around 44% if you get it early, and 3% if you don't catch it early. And So we're looking for hope on the horizon. And so when we get new treatments, and they have treatments now, and the KRAS inhibitors are thought to be what's going to help as we try to eradicate pancreatic cancer. And so these drugs are now in the market, and they give us hope that in the future that we will do better with pancreatic cancer. It still is the cancer for which we have the least likelihood of curing. But we now at least have investigational drugs that will get you in some cases to have a 44% 5-year survival, which is pretty low. But the 5-year survival when it's late is, as you can see, is 3%, which is pretty dismal. And so these inhibitors now are present, and just as we talked about what happened with MS, hopeful that maybe in 10, 20 years we'll be able to do that with pancreatic cancer, but we haven't done that yet. But it's encouraging that we have new medications that give us some hope.
Dr. Callender, there's still the transplant solution.
Not for cancer, not for pancreatic cancer. We don't treat pancreatic cancer by transplantation. Because cancer, the contraindications for transplantation are cancer and active infection. John Buchanan?
Yes, so is there any way, because since pancreatic cancer is so deadly and rapidly deadly, I had one of my co-workers when I taught at Spingarn, his wife had it, and 2 months later she was dead. And then he got it, and 2 months later he was dead. So I was wondering, is there any way to find out if someone has it before it gets to that level where it could kill you?
Well, they're still working on tests, but so far, one of the problems is that pancreatic cancer in its early stage may have no symptoms at all. And so they're still working on new tests, and they're developing new tests to make an earlier diagnosis of pancreatic cancer. But we haven't really gotten to that stage yet. We're getting closer. And there are some tests down the road which may be helpful in making that earlier diagnosis. But I think you put it into the correct perspective. When you make a diagnosis late, the treatment is not good. Darryl?
Yeah, the risk of pancreatic cancer can be reduced by maintaining a healthy weight, stopping smoking, limiting alcohol intake, and avoiding conditions for diabetes.
Correct. Okay. Thank you for sharing that. Right. All important information. Once again, an ounce of prevention is worth a pound of cure. Okay, let's go to the next article. This is along the lines of what Darryl was talking about. This is a suggestion that the management of obesity by bariatric surgery reduces the pancreatic cancer risk. For reasons we aren't as clear on as we could be, obesity is highly associated with cancer. And so the bariatric surgery that is done, and you'll see other articles about the glucagon blocking drugs, which reduce obesity also, thought that to be useful because they decrease obesity. And decreasing obesity by whatever mechanism is thought to be associated with a decrease in the incidence of pancreatic cancer. So, so the bottom line is that whatever you can do to do away with obesity is part of the solution to decreasing the incidence of pancreatic cancer. And that's what this article is saying.
Dr. Callender, what exactly what is MBS? What does that mean?
Oh, that's bariatric surgery.
What is that? What is bariatric surgery?
Bypass. That's where you have bypass surgery, where the stomach is reduced and the food goes from the stomach quickly to the intestinal tract, bypassing the stomach. And this then, because you don't get a lot of food in, you therefore lose weight.
Right.
Then, and we also know that if we can get food to bypass the stomach and go straight to the jejunum, that this results in hormones that decrease the appetite, suppress the appetite, and decrease obesity. So that's another mechanism. There's research going on now. They connect the
How did you know?
oropharynx to the jejunum, and this then produces hormones that decrease the appetite and decrease obesity. Does that make sense to you, or is that?
It does. For some reason, I thought the bariatric surgery was they just go in and cut out all the fat that's in.
No, they bypass the stomach. That's what they do. Bariatric surgery bypasses the stomach.
Oh wow! Okay.
And gets food right into the jejunum, and as a consequence, there's a hormone that's produced that suppresses appetite, and you feel full and you don't eat much, and therefore you lose weight.
Does that have anything to do with your taste? If it's not going in the stomach, does it?
It actually suppresses appetite. The hormone that is produced suppresses the appetite, so you don't want to eat.
Mm-hmm.
So it doesn't have to do with taste so much as suppressing the appetite completely. The appetite center in the brain is blocked.
Hmm.
Okay. There's no question on that. This is an article that talks about chemoradiation for gastric cancer, and there was a talk about using preoperative chemoradiation. And actually, what this article shows is that although preoperative chemoradiation doesn't give you progression-free survival, it does decrease the cancer that you have and make the cancer more operable. And so that preoperative chemoradiation is thought to be helpful in a different way than we thought before. And so that it doesn't replace the resection, but it does result in a decrease in the size of the cancer of the stomach, which means that you may have less surgery, and that in the long run may be helpful. But the difference is for rectal cancer, actually, preoperative chemoradiation may actually eliminate the rectal cancer and avoid the need for anorectal surgery. But that's not the case for gastric surgery. It does decrease the size of the cancer and may decrease the extent of surgery that's necessary.
Dr. Callender, what is resection? What does that mean?
Means that you cut out the cancer.
Okay.
That's what resection means, cut out the cancer. Okay, well, I guess many of you haven't had relatives with stomach cancer, have you? Because that's the stomach cancer that we're seeing less of than we used to. Okay, let's go to the next article. And this is a new option to treat intermediate hepatocellular cancer. We had a member of our group who needed a liver transplant who died, Kevin, right? Remember, John? And they were in the process of treating his liver. And these are some of the mechanisms by which you treat liver cancer. Sometimes these medications will completely eliminate the cancer, and sometimes they will decrease the size of the cancer and allow for improved survival. Liver cancer, of course, is a disease nowadays that when it's relatively local and not associated with metastasis, that we have actually treated by liver transplantation. This is the one exception to the rule. When we talked about the contraindications for transplantation is cancer. This is an exception to the rule. If you have a liver cancer that is confined to the liver and is not spread, liver transplantation is performed in this particular instance. And this is one of the few instances in which transplantation is associated with transplantation. But anyway, the majority of the situations that you have, they may already have metastasis in those kind of situations. The chemotherapy becomes the treatment of choice. Next article, please. And this just points out that these new drugs that decrease weight loss, cause increased weight loss, are now being used for cancer because the same reason that Darryl talked about is that they reduce obesity. And that can reduce since obesity reduces the effectiveness for cancer therapy, any medication that's an anti-obesity is possibly helpful in the management of cancer. And this talks about how GLP-1 is a hormone that in the small intestine that triggers the release of insulin and reduces the production of glucagon, thereby causing people to lose weight. And that's why these drugs, Wegovy or Ozempic, these are GLP-1 blockers that enhance weight loss and therefore may be useful in cancer. We haven't really completed much of the studies to effectively say that this is absolutely the way to do it, but studies are in process. And it is expected that the glucagon blockers will be helpful in the management of many disease entities, including Alzheimer's and cancer. But time will tell on that. Any of you on any of the GPL blockers for weight loss? Anyway, that's one of the commonest anti-diabetic and anti-obesity treatments we have nowadays. And let's go to the next article. But it's good to know about the GLP because they're so common and so popular, so that Dr. Perez.
I was just going to interject how important it is um, with the articles that you have shared this morning. DEI, STEM, because these discoveries, I mean, decades I was told, lose weight, lose weight, lose weight, lose weight. You know, MS was, you're getting ready to sit shivers for people. And it is the young people that the educators on this line have inspired to go in, to be creative, to make life different for so many. And being able to share this kind of excitement. I know now that my mother died because there wasn't this innovation. We didn't transplant diabetics. So many things we closed our eyes to, but these young people, these women, these people who have been injected with enthusiasm by their educators are doing it. That's all I want to say. So keep on doing, educators, what you've been doing.
Thank you, Dr. Perez. So true, so true. Comments are so true that we made a lot of progress, and it's important for that to be shared. And it's also important, as she's mentioned, that the diversity and inclusion, which is being ostracized as we speak, is not thrown out with the bathwater, because we have political aspirations, people with political aspirations who want to eliminate inclusiveness and diversity will be thrown out with the bathwater. And we have to be sure that we don't undo the good that has been done because of the diversity of researchers and research, with the inclusion of people of color in the research, as well as inclusion of people of color in the researchers, as well as recognizing the gender inclusion that is necessary. Of course, nowadays there's so many more women in medical school and in places of education than ever before. The number of women probably outnumber men 2-to-1 in most situations. And so the fact that we now also have included in the research participants more people of color becomes as important as we have people in all aspects of life. Okay, so thank you for your comments. This is another study in which we're talking about the role of adjuvant aspirin in management of colorectal cancer. And the bottom line is that the studies have shown that in randomized double-blind studies that the aspirin group actually had protective effect, although whether it was enough to warrant adding it is another question. But anyway, this is what the study is all about, to find out whether adjuvant aspirin with the chemotherapy, with the other anti-cancer aspects is helpful. And the early evidence suggests that patients did better when they took the aspirin as adjuvant treatment, but not enough so to require aspirin to be part of the treatment, but enough to warrant additional studies. So next text article, I won't go into this because it's one of the things that with all of these studies, you want to be sure, and I'm not sure as I look at the study, that they had enough people of color to say that it applies to all of us. And so hopefully the additional studies will demonstrate that.
Dr. Callender,
Yes.
what does adjuvant mean?
I mean, there's add to it. In other words, in addition to what else you've done, you add the aspirin to it. So that's the adjuvant aspirin that's added to the chemotherapy.
Okay.
Okay, next article. Well, you know, it's interesting that they did a study in Spain to. We've long known that high dose vitamin D is not therapeutic. We know that vitamin D is good, but too much vitamin D is not too good. And it was a thought that maybe even more vitamin D would help for people who had metastatic colorectal cancer. But this study demonstrated that that is not the case. And so high vitamin D is not known to be that great for anything that I know of so far. So. I think some previous studies had made that a possibility, but this study has declared that that is not the case. Next article, please. Now we talk about a new colorectal cancer blood test is here and is now approved. We've got a number of colorectal tests, but that should not make anybody believe that the gold standard is not still colonoscopy, because the gold standard is and is a colonoscopy. And the difference is that the colonoscopy is not to diagnose cancer, although it does diagnose cancer. And the colonoscopy is to diagnose precancerous lesions, adenomas that will become cancers. And so in many ways, the cancer screening tests are okay, and not to be confused with colorectal screening, which is a test that eliminates the precancerous lesions before cancer develops. And so you have to understand that these tests for cancer are after the fact, whereas colonoscopy is actual screening and is the identifying of polyps and other adenomas that will develop into cancers later on, but are not cancers now. And so to think that you're getting a Cologuard test that is telling you that you don't have cancer, it's helpful. But it's more helpful if you get a colonoscopy and find out that the polyps that you have and remove them, because they may then later on develop into cancers. Anybody understand what I'm talking about relative to the pros and cons of colonoscopy versus the pros and cons of these colorectal cancer tests? Because those tests really are not screening tests in the sense that they are diagnostic tests to see if you have cancer, whereas the colonoscopy is a screening test to see if you have a pre-cancerous lesion. So it's important to understand that these tests play a role, but they do not replace the screening aspect of colonoscopy.
And other types of diseases that involve the colon, such as diverticulitis.
Diverticulitis, you mean diverticulosis?
Yeah.
Yeah, okay. Yeah, those are, it's another disease entities that can be diagnosed by colonoscopy.
Another thing, Dr. Callender, colonoscopy is usually covered by insurance, where this test may not be, and it's $900.
Right, and that's because it's experimental. It's now being approved, and so it'll take a while before they accept it here. FDA approval comes first, and then insurance may then decide to pay for it. $900 is money, huh?
Big time.
Yeah.
Betty, your hand is up.
Yes,
Yeah.
Betty.
Yes. I was just thinking about the colonoscopy. I remember in one of our sessions, or even the doctors themselves have said that maybe after 80, you don't need to have a colonoscopy, or maybe more risk because of your age. So suppose you live to be 90 and 90, you know, what mechanism, if they have
Interesting.
pulled polyps out,
Well,
precancerous polyps out before, what do
well,
you do?
it's an interesting question that you raise because it's an unanswered question. One of the Victor Scott, who's one of the colon experts and who does colonoscopies, just lost his mother at 99 because of colorectal cancer. And she stopped getting her colonoscopies at the age of 90. And so the question remains, yes, you can get colorectal cancers after the age of 80. But the reason they have that debate about it is because there are complications from the colonoscopy. And so you could have those. So the question is, what is the greater risk? For you to have a complication with the colonoscopy, for you to have colon cancer. And that's why there's an article which we will talk about later that talks about the shared responsibility of the doctor and the patient having a discussion about the pros and cons of whether or not to have a colonoscopy or to get one of these Cologuard tests. And so most people say it all depends upon the health of the person. If you're a healthy 90-year-old and you have no comorbidities, then the decision to go forward with the colonoscopy or not is something that you and your doctor should decide. With a recognition that if you're frail, then you're probably better off not having the colonoscopy. Janice, you had a question or comment?
Yes, diverticulitis and diverticulosis. And I think I understand diverticulosis is a precursor to diverticulitis. Does it go
Well,
away?
here's what diverticulosis is: an outpouching of the colon, and which may or may not lead to diverticulitis. Diverticulosis is associated with bleeding. Diverticulitis means the diverticulae become inflamed and infected, and it leads to other complications like perforation and other things that can kill you. Whereas diverticulosis is usually only associated with bleeding that usually stops and does not require surgical intervention. Whereas diverticulitis may require antibiotics and also may require surgery. So diverticulosis is an outpouching of the large intestine, which may cause no symptoms whatsoever and no problems whatsoever. Whereas diverticulitis is an inflammation of those diverticuli, which may require antibiotics or surgical intervention.
Okay, thank you.
Okay, all right. And this goes on to talk about the true benefit of screening colonoscopy. And then there's an article that talked about the fact that colonoscopy wasn't as great as people think it is. And this study is taken to go back and look at it and to say that maybe the study was understudied because they didn't include patients. They excluded patients who may have been diagnosed later. So the article's intent is to emphasize the fact that colonoscopy does not treat cancer so much so as to diagnose precancerous lesions and prevent the onset of cancer. And that's the strength of colonoscopy. And so there are many studies that have been thought to say that because it doesn't treat the cancer itself, because once you have a colonoscopy, you have a cancer diagnosis, the treatment is to have the cancer removed. It's by a separate operation. So the question is, how beneficial is the removing of those precancerous lesions? And that's the emphasis of this study, to point out that in order to really evaluate it, you have to include all of the people that have colonoscopy, and that all the people who have colonoscopies who have polyps that are removed are people who would have developed cancer. That's what this study is all about. Now, this goes back to what Betty was talking about. Colorectal screening after 75 is a shared decision, and that is the shared decision making helpful? And their conclusion was no. And that it's kind of an individual decision. And I think the doctor and the patient, if you're 85 years and you're good health, have no comorbidities, and the doctor and you think that your ability to have a colonoscopy without complications is great, then proceed. On the other hand, if there's a debate, now, for example, if you have a positive screen, a positive Cologuard that says you have cancer, that's different, because that means you have cancer, so there's not an issue. And that's why some suggest that rather than a colonoscopy screening, get these Cologuard tests, because if you have cancer, then you need surgery. And if you don't have cancer, then don't bother with colonoscopy. So the decision is kind of, there's no mandate after you get 85. After you get 80, really. Actually, after 75, there's no mandate. And many would suggest that if you're 85, that you, depending upon your health, some people are extremely healthy, no medication, like some we know. And they may decide to do it if they want to. But but this may be a group in which the Cologuard test may be more applicable. Any comments or questions? Because this is a very, very interesting aspect of what to do after 75, get colonoscopy or not. And after 85, even more so.
And Dr. Callender, I'm debating. I'll be reaching that age in a couple of weeks. And I've only had one colonoscopy. I had an endoscopy. But I remember looking at the video of the surgery while it was going on, and it was beautiful. It was squeaky clean. And but that was like 30 years ago almost.
Well, you're supposed to get it every 10 years.
Well, I was just wondering why it wasn't recommended by my doctors. And we did the stool test, every year, but they did not recommend for some reason, and maybe I should request it.
Well, I can't answer for your doctors. The advice is every 10 years after a negative colonoscopy, it should be repeated. Janice, did I see your hand up or not?
No, I was just listening to what John was saying,
Okay.
and the colonoscopy or the flexoscope, I think that's what it's called. I don't know. I thought the colonoscopy is a more thorough examination. I had flexoscope, maybe 30 years ago, 40 years ago, whatever, 30 years ago. And now I'm doing colonoscopies because of that flexoscope. And I have it done every 5 years because at some point years ago, they saw a polyp and now they just track it. And once they see a polyp, understand every 5 years they do the colonoscopy, which have been 5. So I would be one to suggest do the colonoscopy.
Okay. Any other comments? Very important topic. Okay. This is an interesting article for parents and grandparents. Studies suggest youth who take cannabis have low grades and are more likely to drop out. I don't know how you're going to know whether youth is on cannabis or not, because they're not going to tell you, I guess, unless you ask specifically, in which case, will they answer you honestly or not? I don't know the answer to that. But what do your teachers say about this article that they're less likely to achieve A or B grades compared with non-cannabis users? Any thoughts? Is this believable? This is what the research in Ontario says. But that's Canada. That's not the United States. What are your thoughts about here in the United States?
It seems to me that lately, for some reason, when they give those surveys, they're anonymous. So kids are more likely to be honest about whether they use marijuana or not. But I think back in the day, there was more fear involved about admitting that you use it. So there are a lot of kids who were smoking weed, and I just think it kind of makes you stupid. you just sort of lay back and chill out. You don't want to do anything, and you're just happy. Just happy being lazy.
Betty?
I'm not a teacher, but I agree with John wholeheartedly. You can tell, I can tell when someone has been, as opposed to someone who has not been smoking marijuana. So whether it's for recreation or not, or illness or whatever, you can tell the difference. So I can see why grades would fall.
Okay, any other comment on this article? That's interesting. Any other comments? If not, we'll go to the next article.
There's a lot of other things that teenagers do that make grades fall beside that, though.
Okay. Fatal drug overdose deaths down as much as 10%. And then they go through a number of aspects to try to figure out what it is, although the conclusion that they draw as you go down this article is that naloxone and its availability may be one of the reasons. And to me, that's the most likely reason. But we really don't know. But I do suspect that the availability of naloxone may have contributed to 10% decrease. But any other thoughts? Because you guys have children and grandchildren. Is the over-the-counter naloxone possibly part of the reason? What are your thoughts? Any thoughts on this?
I don't have any statistics to back it up, but just a feeling, yeah, that making naloxone available to kids and parents and educators and the nurses, does make a difference. But on the flip side of that, I'm just thinking about all the drugs that are coming in. That's a big increase, and a big increase in use of those opioids. It's unbelievable, and they put it in everything.
Well, a 10% decrease in overdose is a significant decrease, and it makes you wonder. Yeah. So it must be some good's happening at least. Why, we're not sure, but I suspect over-the-counter naloxone may be part of it.
Dr. Callender, from my
Yes.
point of view, what has affected it is that police officers and other health professionals are carrying it around with them. And that's not how it was in the old days. In the old days, when you got hooked on heroin and you tried to get off of it by taking dopamine or something like that, you had to hunt it down.
Yeah, interesting point. Interesting point. Thanks for sharing. Okay.
Maybe, just maybe, people are listening.
Maybe it's all of those things together.
I have a son-in-law who's a police officer, and yeah, they give him these drugs to carry around with him whenever he's in his car or his motorcycle, whatever, in case he runs into overdose victims.
Makes sense. Dr. Perez?
And it's definitely a change in recognition of who is addicted, and a different posture on how we look at addiction. And a lot of that happened in the crisis, so that it looked at more white people. So when white wealthy people had children who and members of their family who were out, who were addicted, we then saw the change. As a Black Panther, in my late teens, we were taught how to treat people who might be addicted, and that was using ice and decreasing, using it under their arms, their scrotum, just like a lot of street treatment. Because that's the way people who were addicted to heroin were viewed. Now that that has changed, there's a different posture. And so, again, DEI is very important now with the influx of different people in addictive disease. It's being recognized as a disease, similar to obesity, which was looked at for a long time as a personal lack of control and discipline. It's real important. So I think, yes, 10% is good. We've known it's been available. People died on their way to the emergency room. And we need more, Anne.
Any other comments on this interesting subject? Do not go to the next article. This is a very interesting article because benzoyl peroxide is probably the commonest treatment of acne. And so to suggest that this benzene containing medication is associated with an increase in other morbidities is frightening. And this article points out that the breakdown of this benzoyl is benzene, which is a product that is harmful. But the problem is that the very few treatments for acne that are as effective as benzoyl peroxide. And so the question is, what's the next step? And and the fact that this could increase the risk for cancer becomes significant. And so it's going to be interesting to see what Dr. Callender, the dermatologist, and other dermatologists will say in response to this recognition that the benzoyl peroxide has the possibility of becoming a dangerous combination. Any of you have had acne as you were growing up? But it's a condition that is not uncommon, particularly people who have asthma, to have acne as well. Of course, and then of course, as you go through the maturation ages, the teenagers and such, acne is a very common problem. And so its use and the use of benzoyl peroxide in its treatment is very common. Any comments or thoughts about the fact that this product, which is commonly used, is carcinogenic? No comment? Okay, good to have, actually I saw the net earlier and Jacobet is back again and Annette is here again. So good to have you all today. And John, how are you doing? You still in the hospital, Tatum?
I'm in the rehab facility.
Okay.
And I'm supposed to be getting out in time to go trick-or-treating in my wheelchair, my rolling wheelchair.
Okay, all right.
But I have an announcement to make, Dr. Callender.
Yeah, well,
On Tuesday, Carol was awarded with her honorary doctor's degree in sacred music from Westland Theological Seminary.
wonderful. You know, but you're always supposed to share the information with us, and you never did.
We will do it now that we have it in hand.
Oh, okay. All right. Congratulations, Carol. Give us
Yes.
a few words. Give us a few words.
A few words.
Dr. Tate,
Okay, it was nice. Family. I just wish John could have been there. Went up to Wilmington, Delaware. It was a nice service at Wayland Theological Seminary, and the realization clicked in while I was there. And there was one man said, "I wonder how they got my name." And I won't tell you the other part, but I always thought that. But it was really nice. And we found this fabulous eating place afterwards. Oh, the food was good. That was a highlight of it. But
Well, congratulations. We're so proud of you.
Mark had alligator sliders. They just had some different food, but it was good.
We
What's
saw
the name
you
of the
in your
place?
robe. We saw you in your robe on
Cap and
Facebook,
gown.
cap and gown on Facebook.
Yeah, and it fit too. I still got it.
Yeah.
What was the eating place you went to?
it was called Wilma's, and it was downtown. First, we didn't know anything about Delaware, and we found some place. My oldest son got that, and it was a drive-through, eat-through, or something. And we said, no, we're not eating here. But it was another, and it had a bowling alley in it, but the food was exquisite. And we tried some different stuff and sample stuff, but it was really good.
Well, congratulations. So proud of you, Dr. Tatum. We'll have to refer to her as Dr. Tatum in the future. So,
Yeah, that's not going to stick on me. But anyway.
well, we shall see.
Dr. Tatum,
Tatum, I am so proud of you. You are an example of DEI.
Well, she's an example
Well,
of
she's an
example of
example
love.
of God knows everything.
Right.
I have never seen a woman who just excels in everything that you can think of. And I'm just so glad that I rub elbows with her sometimes. And it's just remarkable that her energy and devotion to things that are right. So she deserves this. Now, would you give me the complete name of the degree?
Oh, shoot.
Doctorate of
Sacred Arts.
It is
Sacred
an
Arts.
honorary doctor's degree in sacred music.
Sacred music.
Yeah,
How about that? Congratulations.
Okay.
That means she's a Levite.
Yeah.
Well, we're very
Yeah.
proud of you. And what do you say to your big sister, Darryl?
Congratulations. I knew you had it in you right from the very beginning when you taught me everything I know.
Oh. I'll have to let
I love
my
that.
children
I love
know.
that.
I have to let my children know, Carol. You know you taught them in school.
Yeah, in third grade at Amadon in Southwest.
Yes.
When I came from Indiana, they told me
Yep.
they were putting me at the best school in Washington, D.C. And I said, oh.
That's what it used to. They used to clarify it that
Yeah.
way. I don't know about now.
I even saw videos when I was on IU's campus. They were telling me about this school in Washington, D.C. And I was adventurous. We're going, that was in the 60s and 70s. We're going to the inner city, child, and you're going to conquer the world and teach them everything. And there are certain inner city schools that they wanted us to go to the world. And Philadelphia.
House Road, man.
Well,
How many of your
congratulations.
family members were able to attend?
Just my children.
Okay, just your children, huh?
Yeah.
Okay.
And then,
That's a growth.
and then I had a couple of choir members and church members, they went, and I'm waiting for Mark to post that. And we went up Monday night after Monday night dinner, and they decided not to cancel Monday night dinner. So we had pizza and Chinese food where I didn't have to cook, but we still met and then traveled to an hour and a half to Wilmington, Delaware. But it was fun staying in the hotel.
Mhm.
Well, I think that's wonderful, and congratulations. You have been such a magnificent wife and member of this group for so many years, and we deeply appreciate the love that you shared and demonstrated in every meeting, supporting us and supporting John and everybody else. So, congratulations, Dr. Tatum.
You've been a doctor, John, for a whole lot of years.
Well, at least 30 years.
At least 30 years.
Yeah.
You mean at least 30 years?
I said you've been a doctor to John for
Right.
at least 30 years.
No, we nurtured each other. We've been
That's
married.
right.
We've been
Well,
married. We've been
that's
married
good.
54 years.
Yeah.
So
Yeah,
Mhm.
yeah.
That's
But
great.
right.
great.
You're right. Okay. All right.
Very good.
Well, anyway, what a
Congratulations,
wonderful,
Carol. Yeah,
what a wonderful accomplishment.
yeah.
thank
Yeah.
you.
Yeah.
Mhm.
Okay.
Yeah.
Well, you guys have a nice week. October is short.